Welcome to another live recording of the Nursing Home Podcast, the podcast that discusses and deals head on with real issues facing the nursing home industry. In today's episode, we are going to discuss something that we've discussed in the past, something that is very, very real to nursing home administrators, operators, directors of nursing, and that is the nursing home staffing challenge, the staffing shortage and everything that comes with it. So my guest on today's episode is Sarah Wells. Sarah is the founder and CEO of Dropstat. They are combating clinical staffing shortages, burnout, rising costs of care through their solution, Dropstat. Sarah, welcome to the Nursing Home Podcast.
Thank you so much. Thank you for having me, and thank you for making this topic a priority.
Yes, this topic is a priority, not just for the podcast, but for anyone willing to either manage a nursing home or send a loved one to a nursing home, because you definitely want to make sure that somebody send there is well cared for. So just my listeners they know about me a little bit, but if you don't mind giving the 30-second overview of how you got to doing what you're doing today so that we can learn a little bit more about you before we jump into this.
Yeah, definitely. So I'm a 12-year critical care trauma nurse, spent years kind of, on the acute side, on the hospital side, walking through $20 million lobbies and $3 million, $4 million gardens, and then being told consistently that we don't have a budget for staffing or safe staffing, which is really what we call the appropriate staff to patient ratio, and saw how it was directly impacting not just our care and quality outcomes, meaning obviously, I can't be resuscitating with the team in one room and catching early stroke symptoms or complications of fairly routine surgeries in another room. So it was having impacts on our patient outcomes. Notice that it was also having an impact on our revenue. Obviously, you can't admit if you don't have enough staff, and not, God forbid, to refer to patients as revenue, but that is how healthcare facilities make their money, by admitting and caring for patients. So worked my way up to kind of figure out, like, why was there this disconnect where our product is patient care, and yet we seem to not be able to afford patient care, but that is the product, right? That's why any of us have jobs in healthcare. And notice that the process, that the systems that we were using, the workforce management systems, were incredibly archaic. Essentially, if you think about it, we're using Gamma Knife surgery on the 8th floor and minimally invasive robotics on the 3rd, and I'm calling and texting staff to come in like it's 1950. And realized that, I had a tech background, was a bit of a tech nerd prior to that, and realized that this is a scalable solution and required some, improvements on the technology. And realized that once we got in, that we were able to save a whole lot more than expected. I did my own R&D in this space, by the way. I started picking up shifts in senior care, in outpatient surgeries, and saw that this was really a comprehensive issue with a huge addressable market. So it was not just an acute problem, but obviously, as discussed, this is an issue that affects nursing homes. And this is pre-COVID. Obviously, it's gotten a lot worse since then.
Well, so you're not just a tech person who's like, let's throw technology at a problem and see if it sticks. You're kind of really marrying both of your interests together. Something that's very meaningful, something you've experienced. I will tell you, as a nursing home person, our the way our perspective on acute care is that you guys have all the cool gadgets and you have the resources to do what you need to do, including staffing, which is a challenge, but nothing close to what goes on in nursing homes. But it's actually surprising to hear that it's as challenging as you described. And by the way, there was no texting in 1950.
Calling.
But the point is,
messenger, bird, whatever it is we used to.
Right, but the point is, it is ironic, and it should be one of the most important parts of the business. And I will tell you that when I talk to my team, and especially the clinicians, I make sure to tell them that we're in the business of providing care. It's a business, and providing care, and there's absolutely nothing wrong with that. And the more money we make, it's an indication of the good care we're providing, and it also facilitates us to continue providing that and even higher levels of care. So this is something that clinicians get very nervous when we start talking about money, and it really is in their best interest, meaning nurses, hopefully good nurses, become nurses because they care. If we're making money, then they'll be able to care, the verb care, they'll be able to provide care in the even better way. So let's talk about it. You're right. You mentioned that this is even before COVID. What have you seen that COVID has done to the staffing challenge?
Well, like you said, there's always there's the business side of medicine, and then there's the care delivery side of medicine. And in healthcare, we really are perceived as rival gangs, where we're looking out for the best interest of the patient, and we perceive that the business management team is viewing us as a cost and not as a revenue driver, especially in nursing. And that's a really problematic on many different levels, because if you think about it, the tech version of nursing is your client success team, but we're not always perceived as the client success team in healthcare, right? We're just we're a cost, whereas even physicians are perceived as revenue drivers, right? They're bringing patients from their clinics. Some physicians are bringing millions of dollars to the hospital. So nurses have a very difficult time justifying the cost of increased care, but we know and we see firsthand how that directly impacts um, the length of stay, which is not always covered by insurance, right? If there's complications, that's completely covered by the facility. So there's many areas in which nurses are not thought of as revenue drivers, but they very much are. And if you speak to anyone who's had a baby, who's had unfortunately on the other side of the life spectrum, who's had a death in the family, they will tell you what their experience was like with the nurses. But the nurses were either amazing or it was awful. And awful is usually going to come down to unsafe ratios, where they're just completely overwhelmed with double the amount of patients that they're safely able to care for. And if it was amazing, very often it's could be the same nurse, but they just were completely understaffed one day and they were safely staffed another day. So in terms of the business management, there needs to be a lot of healing done, in terms of that relationship. And in terms of the physician side, also, we're seeing a lot of increased pressure on the physicians where we weren't before. You can't really run two surgeries at the same time. So in some ways, they're a little bit protected from that. But the pressure to see twice the amount of patients to make up for the decrease in reimbursement, I think, is probably being felt across the board. So to answer your question, though, where do I think that this has gotten worse? We always had these issues before. This was a problem before COVID. I stepped back to start doing the R&D on Dropstat actually before COVID. We had issues with safe staffing ratios, et cetera. Now, the impacts on acute care facilities are bad. I think the impacts on nursing homes are catastrophic, and I'll qualify that. We lost 500,000 nurses to COVID fatigue, where we knew that we had issues with staffing and reimbursement and how that plays into how we structure our care. Imagine that you have an issue with a conveyor belt and you're able to take out kind of the things that are problematic from your conveyor belt on quality control, from a quality control perspective. But now if you put that on warp speed, you're going to see a whole lot more problems, right? And that's really what COVID did to us. It took this conveyor belt of care that we had, which had issues before, and it fast tracked everything. So what we saw was that in a desperate need to meet the patient demand and the increased flex in census in certain parts of the country, we watched companies that had that were kind of new into this space, let's say travel nursing companies and outsourced labor companies, lure staff away from their traditional bedside models to these much higher paying jobs to meet demand need, and offering $10,000, $12,000, $15,000 jobs. Essentially, I hate to say it's like the nursing home version of colonialism had, hit all of us. And what happened was that you have a resource that was kind of working. It had problems, but now when you take away the team structure and now you're offering them a lot more money and selling back essentially those staff members it was just a procurement problem, right? If those healthcare organizations had perhaps offered a little bit less, they would have still been able to fill those needs. But essentially, it was a diet pill that was never meant to be permanent, right? And what happened was that now that you've taken the supply away from the healthcare systems and you've put the travel nursing companies in the driver's seat, it had a really, really bad impact on the team and the integrity of the team in the hospital and in nursing homes too, from a bedside care perspective. Because now you have your internal staff working side by side with people that are making not 2 times or 3 times their pay, 4 to 5 times their pay. Now, I understand that that was necessary in order to fill quota, but there's no reason for that internal in-house staff member to stay now, right? Because they can do the same job that they love, take care of the people they love. They'll just join that other the travel staffing company and often come back to the same organization that they worked at 2 to 3 times the price. So that's one problem where now it's really hard once you get hooked onto, excuse the expression, I am a trauma nurse. So they got hooked onto this cocaine where they were able to get staff quick and easy, but it wasn't cheap. And it cost them the integrity of their own teams, right? So now they've disempowered themselves, and it's really hard to get that back now because here's what the nurses really liked about travel care. They like not having to do the hours and hours of additional, CEs and having micromanagers that perhaps were intended to be inspirational leaders, but often organizations don't hire the best managers. And once they got pulled away from that relationship, they were like, wow, this is total bliss and freedom. They don't have to put up with, excuse the expression, the BS of working in-house. And that's exactly the words that they'll use if you speak to travel nurses. Why don't you want to go back to bedside? Why don't you want to go back to just staying in-house and having a permanent job? Isn't it more consistent? Isn't it more predictable? They'll tell you, I don't want to have to put up with that. There's a lot of like micromanaging and a lot of oversight that they don't have when they work, these travel jobs. And that really disempowered the healthcare organizations, and it put them in a very, very difficult place to try to meet the costs of the temporary labor, which was now luring their own staff away to other parts of the country.
Hmm.
And where this was vaguely an issue before, now the nurses that had stayed in hotels to ensure that they could take care of their own patients safely and not put their families at risk, these nurses who were incredibly loyal are now getting paid less. They're having morale issues. They risked everything to stay, they didn't leave. And they then had their vacation time, their PTO, and their standard salary increases, cut from 4% to about 2% in many organizations. So they're already feeling hurt, belittled, disempowered, betrayed. And now they had a lot of their benefits cut so that the organization can afford the astronomical cost of care, which became, the rapid inflation of travel and temporary staffing. So that was problem number one that hit with COVID. Concurrently, having nothing to do with COVID, but obviously this is an issue where healthcare needs to take a good solid look at itself. We've never had these many outlets away from bedside, right? Traditionally, nurses worked in hospitals, nursing homes, urgent care clinics. Well, when payers decided that they could get a mid-level for half the cost of a physician, nurses started to have a lot more autonomy in their workplaces and say, why am I putting up with this if I can go back to school for 1 year and make 2 times my salary and just have regular hours and not have to work night shifts and not have to do, a really rough 12 hours, more mental care than manual labor care. And then we have, med spas, and there's so many different things that have just hit the market recently. They converged with COVID, right? So COVID created a huge wage inflation in terms of temporary staffing and luring staff away from the traditional bedside models. But we also had this issue concurrently where we never had these many outlets away and options outside of bedside. And what that does to the pool of staff available to work bedside, obviously, is it dramatically decreases the number available, the number willing to stay and willing to stay with traditional models at the same time that they have a lot more options and opportunities that they just never had. So I guess that's part one. There's so much more
Yeah.
to talk about.
Yes. So first of all, thank you. You've extremely very very eloquently described the problem. This is the problem that I am living. I'm currently a nursing home administrator, and the building that I'm in, I guess we'll even we won't name it for now. But the point is that they've been using agency staff, travel staff, all these other types of solutions forever. And exactly how you described, we have our own staff who have been paid minimally, slight increases, but nothing close to the people that they're working. Literally, they're sharing assignments with people who are making way more money than them. These other people are not on call when there's a call out. They're not the ones who are getting harassed. They are not the ones. Granted, they don't have some of the facility benefits. But most of them either have another job or they have a significant other that has a job. You get the benefits elsewhere, or they don't need it. They can afford to pay it themselves because of the money that they're making, and they prefer the flexibility that they have. To the point that the internal staff, they try to, I guess, emulate some of those perks, even though they're not given to them. So I'm going to call out because I'm in the mood because it's sunny and I want to go to the beach. And even though in the good old days, that's voluntary resignation and voluntary termination, but now what are you going to do? You're not going to call me back for a shift. You need me tonight, and you better give me a raise. Otherwise, I can tell how many people who introduce themselves to me. Hi, my name is Sally. I need a raise. I'm like, hi, nice to meet you. Maybe you need to be fired. I don't know who you are. But it just is, it breeds this sense of entitlement. And like you said, these are some of the finest human beings on the planet. And I'm not exaggerating at all. These are people like you described. They've literally put their lives at risk, aside for regular nurses who do that all the time. But through COVID, these people have worked 24 hours straight, 36 hours straight, like they shouldn't have been, sleeping in empty resident beds or on the floor or wherever it is, not getting paid crazy money. The healthcare heroes thing only goes so far because for the most part, it's lip service, but it does not give them any benefits. It makes us feel a little bit better when they're doing the stuff that the rest of society would never do. But at the end of the day, for them, sometimes it's even hurtful, and they're disempowered in a way. And also the facilities are many times feel extremely desperate. That either you're paying astronomical fees for these agency staff, and I will add that not all agency staff are created equally, but many times the agency staff that come in don't care. Sometimes they're the money chasers, and they're just looking for where they can get the most money, and they're not documenting. And when things happen, they're not sharing falls and skin issues and pain and all sorts of other things. And they're not doing the basics of their job. And that further escalates the friction between the agency staff and the in-house staff. And that makes it even more difficult. There is a silver lining, I can tell you, but because the moment you take back control and you're not scared of losing the couple of people who are going to say, you know what, there's a sheriff back in the house and we're running off. Some of them will, but the moment that you show them that it doesn't matter how desperate we are, we're still going to run this like an efficient organization, and we're going to have rules here, and you guys are going to be out for each other instead of stabbing each other in the back. And we're not going to have one CNA on the shift when there really should be 2 or 3 or 4, and we're not going to have people staying for doubles and triples when they shouldn't be.
Right.
Instead of disempowering them and sending people flying, I can tell you from firsthand experience, it's the opposite effect. People are like, "Where were you until now?"
Right.
Finally taking the power back. So, what do you think? So, we understand that it's a bleak situation. Yeah, go ahead.
Yeah, so I think you have two unique issues that where we said that it's bad on the acute side, it's catastrophic on the nursing home side. What we're seeing with our clients is that so we service hospitals and nursing homes, and so what we're seeing is that magnet status hospitals, where that's kind of the gold standard label that is allocated to healthcare facilities that have great retention and great staffing. So it used to be that the entry level for nurses in magnet hospitals, where there's quote unquote nursing excellence, is BSN prepared nurses. After COVID, we watched that drop to RNs, and then we watched it drop to LPNs, where traditionally those pools of staff were allocated to nursing homes. So their nursing homes were protected. Well, now you have healthcare systems with much deeper pockets, additionally luring your staff away.
Yes, this is
And
true.
this is converging at the same time with boomers having their I honestly think that their impact has not even been felt yet because there's a lot of medications that many of them are on that are putting a lot of comorbid issues at bay. Nursing home patients have never been this sick. Traditionally, you know, there wasn't a home care model that was used to take your stable patients. Well, now that there is one, patients in nursing homes are sicker and their pool is getting smaller and smaller. So I feel like these are the good old days of staffing. And I hate to say that because I know that this has a direct impact on you. But if we look at the fact that there's also 1 million nurses aging out of bedside care, the median age of the nurse, if you look at that, we're looking at losing 38% of our nursing staffing pool
Mm-hmm.
the
Mm-hmm.
next year. So this is not
Okay.
really gonna get better. I think that I completely agree. I think that people like to feel safe in their workspaces and they like to feel like there's standards and that somebody cares about their patients like they do. And when you're advocating for safe patient care by disallowing staff who come in late and don't document and don't provide care, I think there's nothing more critical for your nurses that are loyal and that are good. It won't keep people there who are not invested, but I think it absolutely will keep the ones that you want to be there. And I think that that's what keeps people going. Because if you think about it, they could go right now and get a job at a Starbucks for about the same price and just make macchiatos all day. But they chose to be in one of the toughest um, areas of healthcare where they're doing a lot of manual labor for people who are slowly deteriorating, and you do create connections with your residents, and it's very difficult to lose, residents and to see people deteriorate, and they put themselves in that line of fire every single day. And those are the people that you want to keep, and those are the people who are not going to respect you if you don't care about what they care about, and that is patient care.
This is true. I mean, this is a question that always bothered me from the second I got into this industry, is that why would somebody be a CNA getting paid sometimes less than what they could get paid at, Dunkin' Donuts, at least in Massachusetts, down the block, or whatever, some other fast food chain, and they can, over there, the worst case scenario is that you burned somebody's bagel, you
Yeah.
spilled somebody's coffee. Over here, you didn't provide the proper care. This person got a wound and died. They lost a toe. And why would you do this to begin with? I believe strongly that there's two groups of people. There are the people who, the good people, I guess, who the reason why they do is because they don't want to provide people with delicious breakfast. They want to make a real difference. Not that there's something wrong with being in the retail food industry, but they want to do something much deeper, much more meaningful, and they want to keep people alive, they want to keep people healthy, and it's a calling. And they prefer to make as much money as they can, but they don't want to go there. There's another group, and I'm oversimplifying this, and these are the people who really don't care about if the patient loses a toe. To them, it's the same thing as burning a bagel. And I've seen these people, and unfortunately, these are the people you don't want in your organization. You really, really don't. And these are the people who are literally dangerous to the patients. Sometimes, though, they'll be very, that they will pick up a lot of shifts, unfortunately, and that's when sometimes you have a lot of these issues. But this is really true. Some of the fine, I really say this, that some of the finest human beings are sitting, LPNs, CNAs. They're working crazy hours. They have families. Some of them are single parents. They're trying to put their kids through college. They're doing amazing things, and they're the ones who are going to make sure that the extra touches, extra lotion that's not on the treatment plan is done, just because this is how Betty likes it done, and her hair is combed a certain way. And those are the people that really, really make that, not just experience from a customer service standpoint, but even the care. It's literally can make a difference of life and death. And those are the people that we want to retain in our organizations. Um,
Yeah.
I know you mentioned clients. Tell us a little bit about how Dropstat got started. Sorry, and specifically how it addresses the issues that we're discussing.
Yeah, definitely. So, when we look around, we're seeing like, we mentioned before, and I want to quantify that by saying that I absolutely see tremendous value in what travel and temporary staff bring to the table when they're good and engaged. I don't see that going away anytime soon. But what we want to do at Dropstat is re-empower the healthcare organization. We see the most important relationship is the triad between the patient, the provider, and the organization that brings them together. So that is our absolute priority. So our entire model is completely focused on helping healthcare employers re-empower them and make sure that they have the tools that they need to automate workforce processes that were highly manual and not well managed, give them total transparent insight into their labor costs, whereas now it's kind of a black hole. Like you'll see that there was a bonus applied to a shift, but you don't know. Well, did they try $25 less 2 days earlier? We're always short Mondays 7 to 11. How come we're acting surprised the night before and we add a $200 bonus, right? So there's a lot of kind of black holes of the cost of care delivery. At Dropstat, our vision statement is safe staffing. Obviously, that means safe staff to patient ratios. When we talk about retention, there is nothing that will burn your team out faster than having an unsafe labor load and being accountable to the same standards of practice on their license and being legally and criminally in some cases responsible, as we're seeing lately with some of the cases that are coming out, often due to unsafe staffing. And if you speak to attorneys that are responsible for wrongful death lawsuits, a massive percentage of them all come down to unsafe staffing. So for us, we see safe staffing as the most critical starting block of everything that happens in terms of the cost and quality of care delivery. So our objective is to help healthcare organizations streamline their process, understand their staffing needs well in advance, right? So we think of ourselves as more like the Salesforce of workforce management rather than competing with existing workforce management products. We don't really see that as a competitor. We're looking more at a new category that we're looking to create called workforce automation. So what we do is we use machine learning and AI to predict your healthcare staffing needs 60 days in advance, and we build you an internal marketplace where we're tracking your metrics, your call out patterns, and you can see, well, Monday 7 to 11, we're typically chronically short by 7 or 8. That could be where all your call outs are, right? So you think you're safely staffed, but really that could be your most expensive shift. And that could be costing you more than unfilled shift gaps. Maybe it's easier to fill your Wednesday and Friday, right? So what we're able to do is trace the increased costs of, where are you paying your standard labor costs and where are you paying premium labor costs, whether it's agency overtime bonuses or sometimes a combination of the two of those, which is really, really kind of the kryptonite of healthcare staffing costs, right? So we create patterns and we feed them back to the client and we create recommendations. Obviously, as we're creating recommendations manually, we're training our AI models on that, and that will become automatic. So we're in the horse and buggy days of what we're really looking to do at Dropstat. So the first product we have is our ability to predict your staffing needs, and the next product is our scheduling product, where we're able to automate the publishing of those schedules. 2023. This is the age of facial recognition software. We don't need someone to click, review, and publish, right? So we automate that process. We're able to show the upcharges on the day and where those drivers are coming from in a way that's union compliant. Sidebar, as a nurse, I know unions have a really bad name on the business management side, but I would not have gotten any break probably ever if not for union protection, and especially in busy places like ERs and traumas. And I felt like it saved my ability to provide even safer care, because you don't notice when you're taking care of your patients that you haven't eaten all day and you haven't, So I have a lot of gratitude to the unions that protected me, and my apologies, because I'm sure that there's horror stories both ways. But
this is a whole separate conversation, maybe even another episode, because I'm really curious about that. But let's keep it going.
So in that, we've created a union compliance system so that whether you're union or not, you can roll us out. So we automate decision support, and that means that, maybe Jessica is available from one of your other portfolio facilities, and so is Lisa in 2 hours of overtime, and you've also applied a bonus for anyone who's not in overtime. How do you make a cost-efficient decision? So DropSat just automates that, again, in a way that's union compliant. And obviously, the system self-approves anyone who's not going to be in overtime. So there's automation. So far, there's no schedule involvement, right? You're predicting
Yes,
your
that's
staffing,
this
you're
is my
building in a
question.
place.
Is
It's
the scheduler
self-automation.
managing this, or is this
Correct.
replacing the scheduler?
Well, not yet. So this is where the scheduler involvement comes. They're looking at the screen like they should be looking at the screen like air traffic control, and they should be managing, well, I'm going to use Jessica, who's an LPN, for the CNA shift because I'm down a CNA. So that's the process that we want them to be still managing, right? They have to look at their numbers and say, I have my 8 hours minimum of RN care. This RN will work as an LPN. So as they're doing that, again, our machine learning is tracing what they're doing. And where you say, we're creating more of an automated product, that we're getting there. We're not there yet. We don't have enough data to automate that yet. Meaning all the different inflections and decisions that are possible, but they're permutations. Eventually the product will be able to do that, God willing. So we've also kind of automated safe staffing rewards. We're a partner now with Amazon. So we've created a rewards and retention program. Every time a scheduler approves someone who's not in overtime, they get points towards Amazon gift cards, and it's de minimis. There's no tax issues. And on the staff side, every time they pick up an extra shift, we reward them and we shout out gratitude. We have a gratitude feed that's automated, and it looks like it's organic coming from the admin. And then they get safe staffing points as well. And the rewards program is something we're really proud of, and we're expanding that as well. In collaboration with Amazon. And in terms of, kind of the other bells and whistles that we have also coming, we have kind of a whole mental health platform that's being built out in collaboration with Bayer and a few other products where we're able to track how staff feel after their shifts and kind of shuffle them into the right mental health products that will support them and support frontline healthcare staff. And these are not things that cost extra to the employer. And that's really important because right now there's so much that's changing so quickly in healthcare. We don't want healthcare employers to have to be tasked with things that should be automated as well. This is not just automating superfluous workflows on the scheduler side, but also on the business management side as well. Thanking staff members, shouting out gratitude for, shifts worked on time. Managing the quality of external labor. You mentioned that, you're having issues sometimes where I think it's standard across the board where there's issues with some external labor not documenting. So we have quality controls on that where external labor are rated on kind of objective metrics, arrives on time, leaves on time, and documents appropriately. Like there's other metrics where we quantify whether this is someone that you even want working in your organization. And right now, I think our biggest priority is that we're integrating with a lot of temporary staffing marketplaces. And what that's going to provide us is that kind of source of truth, because you want to talk about the issues that you're having right now with multiple, we call it solution confusion, right?
Yes.
Where staff members now have the ability to clock in on multiple temporary staffing platforms, right? So they came in
but not at the same time.
XRN and eShift may be offering more, and then
I have a problem right now, which because this has not been monitored properly. I noticed some of my own staff coming in through another system, and so I called them, and they're like, "Well, that shouldn't be happening." They blocked them, and now they won't see shifts from our facility. And I called the staff member and said, "Not okay. You work here as actually it was a part-time employee, but you have a set schedule here. This is your facility, and you're going somewhere else just to make a little bit more money. A little bit more money." I said, first of all, it's a horrible message to everybody else. That's not okay. But I want to just jump in on what you're saying. I'm just listening. This is not our first conversation about your product, and I'm trying to wrap my head around it. I see just even before all the specifics that you're discussing, on a high level, administration many times makes good decisions about workforce management, does not have the bandwidth to implement them. So, for example, anytime somebody picked up extra shift it's a no-brainer to give them a small gift card, a thank you, or whatever. But practically speaking, because of everything else that's going on, regulatory compliance, I mean, we don't even have to get started with the myriad other issues. Staffing, even if staffing was fine, managing a nursing home is an extremely complex process. But so the ability to thank them properly is huge. I had someone. I hope she won't be mad at me if she listens to this. But we had someone who worked. Um, hmm, uh, I guess this is okay, but they were on for a double shift and then had to extend their stay, and was not once or twice, and was not happy about it. One of our best nurses, and she resigned, and we had an exit conversation to understand, and all the things that she pointed out was these were all the things that need to be fixed in the building. That's why she was resigning. This was her first job. She loved the place, made sense. We hired her as a director of nurses, and now she's solving some of those problems and trying to pull some of her own friends in. I hope she's not mad at me for sharing that. But the point is that there's a lot of things that we want. The point of that is that I knew that she was on for more than she should have been, and it was on my mind to go over and thank her and give her something and really express how much we appreciate, because we were really stuck, and she did things that most people have never done in their entire life in any profession. It's just because they have patients to care for, but it's very difficult. So having that automated, small thank yous, small gifts, small little something, even if the staff are not stupid, they'll know some of it's automated, but it works. The stuff really works. When you get that email from the store that you went to, it says, "Thank you for shopping here. It's your birthday. Take 5% off." They send it out for a reason, because there's a percentage that respond to that. So that's definitely one big thing. The other piece, which I want to clarify, is that from a scheduling standpoint, if especially a bad schedule, or if you're really in a pinch, you're not looking at which agency is most expensive, who has overtime, doesn't have overtime, who are the people who their week 1 and week 2 shifts are messed up, so that they have scheduled overtime one week and too few shifts, the other week. That'll be a no-brainer to take this one and not take the next one. Does the system already have a feature of prioritizing one that's most cost effective?
Absolutely. I'm glad you asked. Not only do we have a feature that helps you prioritize that and see that, so we have our automated decision support will let you see immediately what your most cost efficient decision is, but you also have the ability to queue them and decide who gets the message, if at all. So you may want to wait a week before it goes to your most expensive agency, right? So you have the ability, both when the messages go out as well as when those staff members are approved. So yes, we do have that capability. And running back to what you said before, we also automate exit interviews. So anywhere where we can send back data to the clinical employer, our goal is to help them kind of be their best friend in this fight, to create a safer staffing environment. We ask them all those critical questions. Did you feel safe reporting medication errors? Would you recommend a friend to go work in this facility? Would you anything that you would want to know as an employer, so that you have better insight into why you may have been losing a staff member who's now going to cost you the replacement cost. Obviously, when you're short staffed anyway, is essentially overtime for every shift that staff member picked up, because there isn't someone who's able to kind of pick that up at a standard labor cost. And then what is the sign-on bonus that you're going to have to get someone to replace that person, right? So sometimes the cost of churn could be higher for some organizations than even the cost of outsourced labor or bonuses or overtime. And what's really important is that we're able to get that data back to the employer. Again, illuminating those black holes of knowledge. Is it perhaps a manager? The cost of not being kind and not saying hello in this industry is something that really we can't afford to overlook anymore. We need people that inspire people to be their best selves, encourage them through difficult situations, and respect and empathize for the difficulties that you mentioned, and the emotional toll of doing this job right.
Well, what about wage analysis? I get the staff come in and like everywhere else they're paying this, and over here you guys are paying the least, and we already adjusted the rates, and I wonder if it's actually true. So we actually have to go call each business office and make believe we're applying, or sometimes you just ask straight out, and sometimes they share, sometimes they don't share, sometimes they share the real numbers, sometimes they don't. And with our messy spreadsheets, we can try to make somewhat of an educated decision if the rate should be adjusted and how and when.
Yeah.
Does the system have any data on that, and how does that work?
Yeah, so we can, we have full insight into what the salaries are across multiple agencies and in your demographic area as well. But that's nothing that you don't have insight and into as well. Like you probably have access to that. We definitely have it, but I'm saying you probably have it too. I would say, you kind of touched on this a little bit before. We need to start adopting kind of the what the U.S. Army has done right? Um, a lot of the PTSD people experience when they leave, they most of the people there don't even have not experienced the same death toll as we have in healthcare, right? And there's a lot of PTSD when they leave, right? So imagine what healthcare workers have to deal with on the regular that we don't acknowledge or support, right? Meaning we have a verified model that it is very difficult to see death and loss on a consistent basis. Now, what they've done right is built an entire culture of camaraderie. They have convinced you that you are brothers, that you're working in these trenches together, that there is nobody left behind. They have built an airtight family dynamic, which we often don't have in healthcare. And if you're able to do that, then you don't have to worry about the $2, $3 raise. If you're able to culture hack and make your team feel loved, valued, connected, appreciated, uh, like they are the key to today's aging population. And if they are consistently fed the value that they have, that their work has, and it's authentic, you don't have to worry about those. It won't come up, and they'll say verbatim to other, yeah, but I love my job. You have people that will delay getting higher level education because that would mean I have to leave my work and I really love what I do, right? So either you're going to have to compete on wage or you're going to have to compete on culture.
Yeah, I mean, the little caveat that you mentioned is critical. It has to be authentic. You can't fake it.
Yeah. I mean, if you drive up what you asked originally, try to think of, what can we do here with or without Dropstat? And I thought to myself, perhaps one thing you don't want to do is, if your staff follow you on social anywhere, um, I would say to leadership teams, be very cognizant of what you are sharing on social. In that, I'm so excited and that event or whatever. Don't drive up in a Maserati where you're telling your staff you can't afford a $2 raise.
I'll
They
leave it
see
at
you.
home.
They see the new house, they see the spend, they see the disparity, and it's going to have the optics of not prioritizing patients. It's not even about them, it's about what they care about, you know? Um, People align when you care about what I care about, and believe it or not, they really do care about those patients. So if we're going to say we can't afford a $3 raise, don't go make a $20,000 renovation on the lobby. Now, I get it from a business perspective. Maybe that's the marketing draw. But then you need to communicate that, right? And the same goes for managing your healthcare staff. Like, we tell our clients all the time where we have blinding algorithms on Dropstat where staff, if they're scheduled to work, Wednesday 11 to 7, they won't see any other shifts 11 to 7. We don't want them canceling their shift and seeing a shift for the same time with a bonus, and then they're going to pick that up, right? So we have a lot of those blinding algorithms, but they still don't fully understand it. How come this person's getting paid, same job, same facility, one of our internal staff members? So it's all in how you bring them into these conversations, because we don't want you understaffed. We're willing to pay more. Jessica has to cancel her plans and find a babysitter. This is not her standard shift. And she's working extra. There's a premium that we're going to have to pay for that. Okay. And we don't want you to be under. If you're fine with being short staffed, we won't pay Jessica. But we're bringing her in and we're having to pay more to help you. Right. So there has to be conversations about all of these things. The things that we do that seem intuitive are not intuitive. You have to explain it the way you have to explain to your kids. Just one more second and I'll stop talking.
Go ahead.
When we look at medicine, right, and we look at who are which children of doctors are going into medicine and are not, what they found was that the ones who say, "Oh my God, I'm on call, I can't," and they just make it sound awful, their kids don't go into medicine. But when they're like, "Dad's going out, mom's going out, saving a life, love you all, you're part of this, you have a role in this, I'm off," and they come back and they're excited and they talk about the case and they talk about the save and their kids go into medicine, right? So it's we can't assume that because obviously we're building a nicer lobby for our patients' families, and because we're spending more money on the TVs for our patients, we still have to make sure that we bring our staff into these conversations and that they understand that it's not that you're not worth as much as a TV. It's that's all this patient has right now.
Right, this is true, and goes against the traditional management of nursing home staff. It has usually been like that divider that we'll deal with the money stuff, you take care of the patients, and things, like I said, you have to develop that culture. Part of that culture is a certain transparency. When you're open with them and you bring them into conversation, not because you have to bring in a CNA into a coffee meeting because you have to check the box, but you actually care about what they have to say and you share with them. They don't need to know everything, but they need to have a general understanding. Like what you said is a great example. I've had that where we did, fancy renovations in a building where the staff wanted a raise. They always wanted a raise. I will also share another point is that I've done a wage analysis more than once in different facilities, determined that we were underpaying and we adjusted the wages. And some people got $5 an hour raises, $6 an hour raises. Right? I think the math is like every 50 cents is $1,000 a year. So these people got significant raises, and these are hourly employees. There was zero difference in their job performance, in the culture didn't get better, the complaints didn't lessen.
Yeah.
Throwing money at problems doesn't solve it.
Agreed.
Showing them that you care, whether it's financial or not, and actually caring and being there for them. And if they're stuck, being there for them, bringing them a coffee, and helping them actually deal with whatever challenge they're struggling with goes much, much further. They should be paid fairly. I've explained to a CNA, let's say, and they're like, "I've been here for 30 years. I'm a great CNA. I want to get extra $10 an hour." I said, "Okay, and I also want to get paid like a celebrity. That's very nice, but you're providing a certain level. This is economics 101. A CNA at the end of the day is just a CNA taking a role. It's very important and it's amazing. Maybe you should become a lead CNA, which you became. And maybe there are things that but for this value, this is how it works. You want to, grow from there, you can grow from there." I'm seeing the time here. We blew way past our deadline, but just because you're bringing such great content and just really what's going on in the trenches, using your example, I guess. But if we just want to wrap up here, we want to leave our listeners with a final thought about what they can do, in order to cultivate the staff that will actually want to stay and bring their friends. Like, what would you say is something that they can do for that?
I think the most important thing is to listen to your nurses. That sounds so basic, but if they're saying that they're struggling with a manager, you could very well be getting gaslighted. What we see with our systems, once we have total transparency on the process, unfortunately, we have found fraud, and often it's within schedulers and members of management teams, where they're the most loved, right? Don't presume that because someone presents well to you, that they're kind to their own staff, right? So, and I hate to bring that up because
That's ugly.
never wanted to be the IRS of like, but once we have full cost tracing, we see the red flag patterns, and it's typically shocking, right? It's never the person you thought it would be. It's always the person who's so nice and so, and doing the most. So I would say listen to your nurses. That's going to get really expensive for you on the retention on a churn level when you don't listen. Just assume that they're right. Investigate as if they're right? They may not be, but just investigate as if they're right.
I know we had a case where we had a certain resident was taking a certain PRN medication only when a certain nurse was on. Every single shift the person was on, they had it to the max and never ever any other time. And that was the first red flag that led down not such a pretty path until we saw what was going on, you know, the drug diversion. So,
Yeah.
but that's only because we manually had some questions and happened to come upon, and this is all very manual. But I can imagine that if you have this data, you know, so transparent, you're gonna see the truth, the good, bad, and the ugly.
100%. Yeah. And then, you know, besides for listening, I would say be willing to change the way you've done things for years. Medicine is different. Healthcare is different now. We've experienced a massive shift in how things happen, and um, staff are more in the driver's seat now than ever. They have so many
Hmm.
different outlets. You're going to have to make the case to stay more compelling than you ever thought you would. So we're doing our best on that. Just to set expectations here, I want to clarify: Dropstat is not for everyone. For organizational teams that don't have good operational management, we are not a diet pill. We're the the best chef, the best gym, and the best, uh, personal trainer. But if you don't have the ability to implement, and you don't have the ability to ensure that policies are properly managed, you're going to have a really tough time these next 5, 10 years having nothing to do with Dropstat. So we are not the silver bullet. But when you have an engaged team and you are able to manage, and you have someone internally who can be an internal champion, it's a great product to be able to kind of be your best friend in this fight. Um, and I think we're going to have a lot more of these kinds of conversations where everybody comes to the table and just says, here's what's working, because look what's good for you. You can't gatekeep now. Like, this is all hands on deck. Everybody needs to help each other. And things that can be automated at scale, like gratitude, like we have an event product that we're going to go live with soon, where we can trace, okay, these facilities are doing great on retention, and they have 7 or 8 internal events, like your holiday parties, your potlucks in the break room. That contributes to great culture. That lets people see each other in and out of work, not just in the high stress trenches, right? We have to see each other as people. We have to connect, um, with our families, and provide context to the person that you're seeing just in a perhaps a tough environment. So I'm excited. I think there's a lot of positive changes coming too. And this is an opportunity for us. This specific podcast is not just a conversation. It's an opportunity for people to come to the table and say, here's what's working for us. And here's what's likely to work for you. And share and grow together.
Amazing, amazing. If somebody wants to learn more about Dropstat, they want to see if this is something that makes sense for them or their organizations, what's the best next step for them?
Yeah, they can email us at info@dropstat.com, or hit up any of our staff members on LinkedIn, and we'll do an assessment and see how we could be helpful.
Amazing. So Sarah, again, this is Sarah Well, CEO founder of Dropstat. At least I said it right this time. I really appreciate you coming on the Nursing Home Podcast, sharing not just your background from Dropstat, but also as a nurse, kind of seeing both sides of the fence. A lot of conversations that can come out of this one. Specifically, I want to maybe touch base about the union conversation, but maybe we'll have to table that for another time.
Yeah.
But really, thank you so much for sharing all that information with our listeners.
Thank you. Have a good one.